So we'll move on. Move on. Ritika is doing. You're doing next, no? Okay.
Is it? Okay, fine. Good afternoon. I'd be taking you over perhaps the most common complication that every cataract surgeon has to encounter in his or her lifetime, managing a PCR. So this is something that you can face in even the simplest cases to the most complex cases. I'd basically be making 4 simple points through a series of video. First is to not panic. Second is to maintain your chamber and your calm. Third is to manage the vitreous. And fourth is visualize and implant the IOL. So let's start with the first case. I'll just be using each of these cases to drive home a point. This is a patient with a pre-existing large PC rip. This is a posterior polar cataract. So whenever you are I'm using a femto platform here. So you see here, I am showing you the integrated OCT just to make you understand that the epinucleus cushion is a great buttress to prevent nucleus dropping. So this is the end of the case, but I'll just try to see if I can pause. So you see that even at the end of the case, the epinucleus, even though there is no posterior capsule underneath, if you do a good hydrodelineation, do not do a dissection and take care of the epinucleus cushion, you will be able to do a good nuclear management. Now, when you are removing the cortex, approach the area of the deficient capsule in the end. This is the take home point. Sorry, I think it's blurred. Now, when you have a PC rip, you have to maintain your chamber. You can do it more predictably here because you're anticipating a deficient PC, but even when you have a PCR that you are able to detect and you're operating a normal case, please move to irrigation. Do not aspirate anything. Stay with your phaco probe or whatever instrument you have. In this case, it's the coaxial IA. Then you get in from a side port viscodispersive agent, the cannula, move from 0 to 1 and start injecting the viscoelastic. I will drive home this point using the anterior segment OCT. Can you see here? There is a bulge of the anterior hyaloid phase that you see on the, I'll just move back to show you the, so this is the anterior hyaloid phase that you will see now. Once you can see here, this is the vitreous coming out, right? So if you decompress the anterior chamber, just the pressure differential will get the vitreous to herniate out. Just putting viscoelastic, if you've completed the case and you know there is a PC rip, will prevent you from managing the vitreous. So it is important to always tamponade. Moving on to another case, this is to show you that sometimes when we face vitreous, we just don't change our mindset and we are trying to wish it away. This is a surgeon who's faced a vitreous, uncomplicated cataract, the rexus has extended and that has caused a PC tear. So what is happening in this case is that the surgeon is using the IA to actually manage the vitreous. Please note that the vitreous has various components. It has collagen, it has hyaluronic acid. So though you're able to suck the hyaluronic acid, the collagen will plug your aspiration ports and your phaco ports. So doing these maneuvers with vitreous, you see here that the vitreous is actually being dragged. This is a tag of vitreous that is being dragged. When you drag the vitreous, you're pulling on the peripheral retina, which can lead to tears or detachment. So this is something that you don't have to do. Do not aspirate the vitreous. Switch to a cutter and do not sway your instrument thinking that you can pull the vitreous and shred it. Absolutely counterintuitive. Now the surgeon moves to a vitrectomy approach. What is the problem here is that the vitrector has been inserted through the main port. So you do not have a stable chamber. Because of the hesitancy the irrigation keeps coming in and out. You are decompressing, you're just attracting more vitreous into the anterior chamber. This is not the right approach. Finally, a senior surgeon steps in and you see now that we have a decoupled approach and a vitrectomy with a high cut rate is being used to manage the vitreous. So a vitrectomy has to be used with a high cut rate, and then of course once the vitreous has been cleaned off, you can go ahead with the IOL if you have enough capsular support. Now moving on to a case of traumatic cataract. This is a case of traumatic cataract where we feel that it's a very fluffy cortical matter which should easily come out by aspiration. But we note that it is not coming out by aspiration. Why that is so is that it is admixed with vitreous. Whenever vitreous comes into your port, like I said earlier, it clogs. So there are two approaches to removing the vitreous. The first you see here is the anterior approach or the posterior approach, the pars plana, and second is the anterior approach. If you are removing vitreous through the pars plana, you are actually getting it back to where it belongs, right? You pull it back. Whereas if you are doing an anterior vitrectomy, you risk pulling more of the vitreous. So there have been now instances where we have moved to pars plana, and as anterior segment surgeons, if you get over the mental block or if you have a good posterior surgeon support, you can always also look at the pars plana approach. In this case, because the PC was also dehiscent and we had and with the traumatic cataract there was some vitreous hemorrhage, so we are making a pars plana approach. We are using a vitrector to both remove the cortex and the vitreous. Please note that through this method we have two approaches. One is the cut and aspirate, second is the aspirate and cut, right? So when you are looking at the vitreous, you are using the cut and the aspirate, because you first cut the vitreous, then you aspirate. In the cortex, you sometimes need to aspirate and then cut, right? And note that whenever something is thicker, you can lower your cut rate. Vitreous gets better removed with a high cut rate. So please note these two modes and use it to interchangeably manage both the cortex and the vitreous. So this is how this case is being managed, and there is good capsular support 180 degrees apart. So though the AC and the PC have vertical rips, but there is enough support 180 degree apart to put in a 3-piece IOL. So that is what we will be doing. So you look here. The problem that you're going to, if you see here, is that there is a vertical rip and the IOL just dips down through the dip. A good mechanism to avoid this is you don't insert the whole IOL, keep one haptic out. As a young surgeon, you may also suture, like Dr. Gaurav had shown, into the CTR if you feel that the IOL may not be as stable. However, we are able to dial the IOL well in this case, and therefore the IOL sits well. Now I'll be just showcasing a small video to show you the posterior approach. Another important thing that you must note is that vitreous stains well with triamcinolone, because the triamcinolone impregnates the various pockets in the vitreous. So this helps you detect the vitreous, and though the older videos don't have triamcinolone, I'm going to show you a recent video. Now this is a subluxed cataract. Because there is vitreous in the anterior chamber, again you will not be able to do phaco because vitreous will clog the port. So this is a triamcinolone staining. You see when we are using the posterior approach, you see how it just moves back. This is how it moves back and things get cleared up. This is the end of the surgery where we feel that we have cleared off as much vitreous as is there, but you see the triamcinolone is helping you detect little strands of vitreous that are actually incarcerated in the wound. So triamcinolone staining and visualizing vitreous in its entirety is very important intraoperatively and even at the end of surgery, so that you don't leave a patient with incarcerated vitreous or vitreous in the AC, because this increases your risk of corneal damage, glaucoma, CME, and post-op retinal problems. For those who want to move on to the pars plana approach, I'm just showcasing a small video that we now have. We have a 23 gauge trocar cannula system that we usually use. This is how it looks like. This is a typical non-valve trocar cannula system. This is a 23 gauge trocar cannula system. This comes with 3 scleral plugs also. Is the audio? So this is the spear-shaped trocar which is threaded over the cannula, right? This is inserted in a phakic eye. We are inserting this 4 mm from the limbus in a biplanar manner. First you go parallel and then perpendicular. You just retract the conjunctiva, first moving parallel and then perpendicular, a biplanar. When you feel that there is a pre-operative risk factor, it's obviously easier to place these before the surgery when you have an intact globe. This is the infusion. You can always plug it at the other side and use the vitrector as and when needed. Right? So with the modern instrumentation, using the pars plana approach has become easier. Now another case wherein, again, this is the posterior polar cataract. The femto procedure is being done, and during surgery it is evident that there is a large posterior capsular rent and half of the nucleus, the heavy nucleus, is still in place. This is a relatively softer nucleus and it has been cheese wired by the femto cutting pattern. At this time, a visco-dispersive viscoelastic has been used beneath the nucleus to give a tamponade, and we are trying to levitate the nucleus into the anterior chamber because this is a soft nucleus. Even if we want to emulsify it in the anterior chamber close to the cornea, we will be able to get away with it. The problem that happens is the femtos already cheese wired it. So do note that we make a paracentesis exactly opposite and use blunt instruments to bring it into the anterior chamber. We are now using an IOL scaffold technique where an IOL is inserted over the iris because the visualization is not perfect, and then you simply use a visco-dispersive to protect the cornea and emulsify the soft nucleus. I would not do it in a very hard nucleus because you risk endothelial decompensation. Once the cortex has been cleaned up, this very same 3-piece IOL can be dialed into the sulcus. A note to IOL power adjustment when you're looking at a 3-piece IOL in the sulcus to the tune of 5%, approximately 1 diopter, is an important thing that we sometimes miss. So the IOL power has to be adjusted if it's been put in the sulcus, and now a 3-piece IOL has been put into the sulcus, and this is the end of the surgery. So thank you for your attention. If there are any questions, I'll be happy to answer.
Ashish, you could get your presentation ready. Any questions to Dr. Ritika? An extensively covered to PCR and the management of a nucleus during capsulotomy and PCR, and the use of a trocar cannula. As she has mentioned, using trocar cannula as an anterior segment surgeon will be a little challenging. We'll think that it is very difficult and all. So if in a compromised soft eye, if you're trying to do this, it will feel more difficult. So try to learn it in regular eyes. Go to VR rooms, ask them to give you a chance to do that, and get the globe firm before you insert a trocar cannula, especially when you have a compromised situation like a PC rupture.